So we are starting with a sphincterotome. So as I told you that most of sphincterotome, virtually almost all of them, barring the specialized ones, are pre-curved. So pre-curved meaning there was the near the tip it will be curved, and it will be curved with the purpose that it will help in cannulation. So most of the sphincterotomes are now cannulating a sphincterotome. And I told you that the last class that cannulating a sphincterotome are supposed to be curved sphincterotome, pre-curved, and they are little softer than a standard sphincterotome. So that is the difference which has happened. Previous generation sphincterotomes were not curved, like Tritome, which is from Wilson Cook. That was a standard. Tritome was not a pre-curved sphincterotome, and when the pre-curved version came, then it was labeled as Tritome PC. PC is standing for pre-curved, not for personal computer. Okay. So that is how it is. So it is curved to make suitable, but you have to understand that all pre-curved sphincterotome are inherently designed for the biliary cannulation, because at most of the centers, the biliary work is more compared to pancreatic work. So they are designed for biliary work. So as of now, you don't have much of a sphincterotome available which is completely dedicated to pancreatic cannulation. So you have to use the same with some either pre-grooming or by the changing position, and then we use for the pancreatic duct. Most of the time we change position and orientation inside and use the same tome. Otherwise, on the finger you can change it. So anybody who has who got opportunity to work with me in the ERCP suite, he must be aware of it. So when we try to groom the sphincterotome for biliary cannulation, we always groom on the left index finger. And when we are trying to groom from the pancreatic, because pancreatic orifice will be always towards the right, you want to go towards right. So you groom on the right index finger. How do we groom that to be demonstrated? Then I had talked about the cutting wire. So cutting wire, I had explained you, we have two types of wire. One is monofilament wire and second is braided wire. So braided wire is made of multiple thin wires, which is braided like ladies' ponytail, and they made into one. So the way we get electrical wire in our houses, so there are multiple wires and which are lying together in insulated sheet. So here there is no insulation as such, but monofilament there will be single wire. But you must have read in physics about the eddy current. So current flow is because of eddy formation is gets slightly restricted in monofilament. So that was the philosophy of using multiple thin wires even in domestic connections in place of single thick wire. So the same was used, but that used to give less strength, and braided wire used to give more strength, because the same cutting wire is used for bending the sphincterotome. So you have to understand, when we see the picture, then I will explain you that same wire. So if you bend too much, what will happen? That ultimately the wire breaks down. That is how most commonly we lose sphincterotome. So the reason for breaking of the cutting wire are two important reasons. There can be multiple, but two important reasons. One is you use too much force for bending, like your scope is, your sphincterotome is stuck in the channel. You are using long nose sphincterotome, and it is deep into the bile duct, and the anatomy says that it is not letting it bend, and you apply too much of force, then the wire will break down. The second reason, which is more common, that out of inexperience or negligence or deliberately because of position limitation, you keep the cutting wire inside the channel, and partly inside the channel and partly at the papilla, and you start cutting. So if any time it touches the elevator, there will be short circuiting of the current. And you always know that what happens in short circuiting, always your fuse wire goes away. So here it acts like a fuse wire and it gives way. So you should always be cautious that when you are doing a sphincterotomy, the proximal end of your cutting wire should be visible. So these accidents and incidents will not happen. So that is important. So what happens that braided wire will give non-uniform density of current, and the cut margin using the cut made by the braided wire will gives a serrated appearance. In contrast, the monofilament wire will give uniform current density, and the cut will be nice, fine cut like a incised wound. Incised wound, you get a very clean cut, so that type of. Then earlier we used to have double lumen sphincterotome. So double lumen, what we used to have one lumen for the cutting wire and one lumen for the guide wire. So what used to happen that if you have guide wire in place, you will not be able to inject contrast. Or if you are injecting contrast and then put the guide wire, then you have to flush properly. Otherwise, contrast will coat whole of the guide wire, and which used to become sticky, and the exchanges used to become extremely difficult. So double lumen sphincterotomes are virtually have gone out of fashion, except in certain situations where we are using a specialized tomes or very thin dedicated ERCP scopes for children or neonates. So there it is available on demand. Most of the sphincterotome now are triple lumen, and what are the three lumen? I told you in last class that one lumen is for the guide wire, one lumen is for the cutting wire, and there is another lumen for injection of contrast. So injection of contrast lumen has to be separate because contrast is very sticky, and if it coats the wire, then exchanges becomes very difficult. Most of the sphincterotome of current generation will have the shaft diameter of 7.5 French, and the tip diameter will vary from 4 French to 5.5 French. All traditional ones to 5.5 French, but the taper or the newer sphincterotome 4.5 French we are going to see. Then I explained about the cannulating sphincterotome. So most of the cannulation now is done using sphincterotome. The advantages are that you require less exchanges, so cost becomes less because this is pre-curved device, so easy to cannulate. And then using the cutting wire, you can bend and adjust the things, and the things are faster. Things happen faster. So for that convenience, most of the time it is a sphincterotome which is used for cannulation. So this is what I'm showing you just for historical reason. Otherwise, this may not be of relevance now. So Ultratome, last class I explained you that this is from Boston Scientific, and Boston Scientific used term when you have double lumen, this will be the name, and when you XL word is used, that becomes triple lumen device. So XL stands for extra lumen. So Ultratome is a double lumen pre-curved sphincterotome. So it will be pre-curved. So as I explained you, there will be a cutting wire, and this cutting wire here is a monofilament wire, and the segment of the catheter, which is ahead, it is called tip. And last time I explained you, tip are labeled as tip or nose. So this can be short nose or this can be long nose. So anything which is less than 10 millimeter will be called short nose, and anything which is more than 10 millimeter will be called long nose. So in microvisive or Boston Scientific, it comes in the length of 5 millimeter and 20 millimeter. So short nose will be 5 millimeter and 20 millimeter will be long nose. So I will explain you subsequently that there is one which is available noseless, that is called pre-cut sphincterotome. So there the guide wire, actually cutting wire, comes from the tip. It loops like this. So there is no segment of cannula ahead of that. So that is basically pre-cutting sphincterotome. So that will be not shown here. So short nose and long nose is, you understand now. So I had explained to you in last class also that short nose give you more flexibility. So bending will be better, easier, will require less force, and you can easily bend, and you can remove the bend, so you can straighten also easily. In contrast, the long nose we use where we want more stability. So there will be long length of a catheter ahead of the cutting wire. So that goes into the bile duct or pancreatic duct, whichever duct we are working. and then it gives you very stable cutting wire position. So precisely you can cut at a orientation you want. So you want more stability, then you have enough space there, then you will use long tip. Otherwise, routinely we use short tip because that gives you better maneuverability and better control over it. Stability generally we achieve by our manipulation rather than with the help of sphincterotome. So you can understand 20 milliliter if you have a stricture, say for 1 centimeter or 1.5 centimeter from tome, then obviously you will not be able to accommodate the long tip. So in that situation, you cannot use. So that becomes limitation of long nose sphincterotome. But theoretically, you should know that long nose is for stability and short nose is for better maneuverability. So most of these will be color coded, like handles will be color coded to show one thing for sure, that is compatibility with 0.035 guide wire. So every company uses different system, but there will be a color code. So whichever company you are using, you should be aware of that. So simply by seeing the handle and the color out here, you will be able to know whether this tome is compatible with the 035 wire or not. So here you are seeing that Ultratome is compatible with 035. And when we say 035, then I understood that all smaller diameter wire will be compatible. But there is one more point, that thinner wire, sphincterotomy is done only on protected wire. We don't do sphincterotomy on unprotected wire. So we will not be doing like Pathfinder or Roadrunner wire. Or those wires we don't use for. We don't use for sphincterotomy. So that precaution should always be taken. Okay, so this is double lumen pre-curved. So again, 5 millimeter and 20 millimeter nose. So short nose, long nose. And the catheter length here is 200 centimeter. Whole of it will not be usable. Usable length will be approximately 180 centimeters. So that one should remember. And the shaft diameter is 7 French and the tip diameter is 5.5 French. This should be remembered because I have seen many people that even if they intend to place 7 French stent and they do a sphincterotomy and there is a stricture, they pass the sphincterotome and still they are struggling with dilator or looking for dilator. No, when somebody has passed the sphincterotome and in the sphincterotome approximately little proximal to the cutting wire, there will be a step at which place the diameter changes from 5.5 French to 7 French. If the tome has been passed completely across, then 7 French diameter has been achieved. So that much dilatation we have achieved already. So placing 7 French stent, we need not dilate. So basically, one need to know the diameter, all the diameter and lengths very clearly for the optimal utilization. So here you are seeing this, you have to remember this image very clearly. So what you have here, a guide wire, and then you have a cutting wire lumen, and then you have an injection port. So this is how triple lumen sphincterotome is. So there are three lumens for three purposes. But note it that the guide wire lumen is eccentric here. So Ultratome XL is a triple lumen sphincterotome. Everything will be separate. Cutting wire, guide wire will be separate. Injection will be separate. So the guide wire will not be contaminated, will not get coated with contrast. So that is the advantage. And short nose and long nose, I explained that 5 millimeter and 20 millimeter. And the tip diameter is 5.5 French. And the shaft diameter is 7 French. That one should remember. And catheter length is 200 centimeters. So that is important to remember, because this is important to remember, because if you start using it with double balloon, it may not be sufficient in that scenario. So that's why one has to know all the things. So Ultratome XL, I told you extra lumen, triple lumen, 3 lumens I explained you, short nose or long nose. That long nose is for better stability, short nose for better maneuverability. Cutting wire, you can opt for either 20 or 30. 20 is the norm. Longer cutting wire becomes liability actually. So if you have very long wire, then I told you that you require only 1/3 of the wire to go inside for cutting biliary sphincterotomy or pancreatic sphincterotomy. 2/3 actually should be hanging. So basically, we are utilizing only half of the wire because rest will be seen. So if you take a very long cutting wire, 30 millimeter, then obviously that most of it will be in your lumen and then lumen of the scope. So scope, because of get short circuited, the guide wire, the cutting wire will melt away because it will come into contact with the elevator. So all those things will happen. So that we try to avoid unless we are compelled by the local anatomy. When we are doing sphincterotomy, because of anatomical reason, from a position which is quite away from papilla, then we will be using 30 millimeter. Okay. Then the next generation is tome, is Truetome. This is again from Boston Scientific or Microvigic. So this has multiple advantages over Ultratome XL. So first of all, because we have a fixed diameter, I explained you that all these sphincterotomes are designed to cannulate the bile duct. So it is inherently when it comes out from the channel, it will be directed towards 11 o'clock position or 12 o'clock position or 10 o'clock position. So towards the left side slightly. So when we are doing pancreatic work or pancreatic cannulation, that becomes slightly difficult or cumbersome. In that situation, we want to rotate. So so far what we used to do with Ultratome XL, that either we used to groom and change the direction of curvature of this pre-curved sphincterotome manually, or we used to change our scope position and accordingly we used to succeed mostly. But now we have another device available, Truetome. So where what has happened with the help of handle, it is possible to change the direction of tip and direction of orientation of sphincterotome. So that I'm going to show you short while. So that is one thing which has changed. Then what has changed, the tip diameter, if you remember in Ultratome XL, I explained you that tip diameter is 5.5 French. So that is little bulky tip. So if you get a little thinner tip, that becomes easy, and particularly if it doesn't become traumatic. So what here the tip diameter is 3.9 French to 4.9 French. So it is available in 3 sizes. Commonly in common language, we call it 39, 44, and 49. So this is basically French, 3.9 French, 4.5. So that is. So 3.9 will accept only 0.025 guide wire. So it is not compatible with standard wire which we keep using, only 2.5. The rest two are compatible with 0.035 guide wire. So that is important to know. Third thing which has happened in Truetome is the lumen of guide wire lumen is absolutely centric. So if you remember, I showed you that Ultratome, it was completely eccentric lumen. So that used to create little difficulty as a cannulating sphincterotome. So that difficulty has gone away with the availability of Truetome. So this is completely centric. And these margins, the tip is very dome shaped. So this is very smooth and dome shaped. So this easily slips into the bile duct or pancreatic duct. So cannulation has become easier. So that is the another advantage. So this is wire guided. This is central injection port lumen, central guide wire lumen. So that is another advantage. And control stability. So you can see that it can be in this direction and then it can go to pancreatic duct, or it can made to go. So this is neutral position, and then this is biliary position, and this is pancreatic position. So it can be changed. The another advantage is like in the previous device, we had the cutting wire which used to control the curvature. So this is the cutting wire, and this is used for pulling, and then the curvature of the sphincterotome increases. So that was used. So this used to be normal device. So as you leave, it used to go in normal position. But here we have a brake system. So how does it work? So there is a one device called friction plate. So in the handle, if there are friction plate, it tends to remain at the place where you have left. So it will not completely remain there. It will try to revert in the normal neutral position little bit, but will not fully. So it tends to maintain the position where you left it. So all the time you need not hold the device completely. So again, you can see configuration that cutting wire vary from 20 to 30, which is the hallmark for all the companies, which is standard for every company. They will have tomes available in 20 and 30 millimeter cutting wire. 20 and 30 millimeter cutting wire. And the tip length is 5 millimeter, and the catheter length is standard 200, which I said approximately 180 usable length. So next sphincterotome is Clevercut. This is from Olympus. And this orientation wise, comes slightly different. This is also available in double lumen and triple lumen version. Mostly double lumen is not used, so mostly triple lumen. And this has a different type of marking system. Color is also different, and the length marking is also different. And this is available in 3.9 French tip diameter and 4.5 French tip diameter. And the shaft diameter will be 7 French, so which is same as Ultratome. So basically, this is like Truetome. Truetome is available in 39, 44, and 49. Similarly, this is available in 39 and 44. And the working length is 1950 millimeter, that is 195 centimeter. So that is again 200 centimeter or 180 centimeter. So that is like that, and compatible with 035 wire. So same again, it is pre-curved. So you can understand this is equivalent to Ultratome XL. This is not a steerable device, so it cannot be bent. But there is one advantage, that half of the wire is insulated. So that is the clever about the Clevercut. So accidentally, the question of touching elevator is virtually doesn't arise in this situation. So that current short circuit to the patient, to the scope, and scope damage, all those the risk is minimized. So again, the working length there, I told you 180 centimeter, here 170 centimeter, 20 millimeter and 30 millimeter cutting wire. And again, 4 French and 4.5 French tip. And the short nose will be 7 millimeter here. It was 5 millimeter in case of Boston Scientific, and 30 millimeter in case of long nose. So it can be, you have the option of either 15 millimeter or 30 millimeter. So yeah, here you have 3 length of nose, 7, 15, and 30. So 15 you can say intermediate, but by definition this will be long nose. Okay, so then comes the micro knife. Micro knife is also a triple lumen device. So rest of the functionality is same as triple lumen Ultratome XL. So you have a contrast port, you have a guide wire port, and then one you have cutting wire post. And again, this is a pre-curved device. One can always argue that why you require a pre-curved device when you are using needle knife, but because most of the time we use it for pre-cut sphincterotomy, so then it is convenient. So it will have. What is most important, that it is the length of the needle. The length of the cutting wire or length of the needle, because this is important. If you use very long needle, then the risk of perforation will be inappropriately high. So as you understand, the thickness of the wall of the GIT, particularly in duodenum, is thin, and it is approximately only 3 millimeter. So it should be very short needle. So it is kept as 5 millimeter because we are working at papilla, and not whole of it will be used for cutting. So 5 millimeter, and the shaft diameter is again 7 French. and it tapers down to 5 French. But most importantly, that it will have a guide wire guide wire facility. So at any stage of cutting, when you are sure you want to check whether you have opened up the pancreatic or biliary orifice which you were trying for, then you can pass it. There are other different uses for it. So most commonly earlier when we are doing initial stages cystogastrostomy, or wherever you want to give free hand cut, there like Jenkins diverticulotomy, when we were using the needle knife device for cutting the septum in that situation. So the guide wire, if you want to place, then you can just advance the guide wire there, and that's why it is a triple lumen device. So this is called from needle cut 3V. This is from Olympus. So again, very similar device, virtually all same features. And this will, again, diameter is virtually same, and it is again compatible with 3.035 guide wire, and the tip diameter is 5 French. So there it was 5.5 French. So Cystotome, partly I covered in last thing also. So this is not a pre-curved device. Unlike the microknife or pre-cut sphincterotome or needle knife, triple lumen needle knife, this is not a pre-curved device, and this has a electrode out here, but this has which is works like a needle knife for making puncture. But this also has a electrode out here which is used for cannulating. And the second difference is this is a 10 French device. So 10 French is 3.3 millimeters. So all other devices we were talking were 7 French device. So this is for designed exclusively for doing cystogastrostomy. So this is used for making hole through the duct, and then this is used for coagulating the wall. So that is how in one step everything is completed, and then you put the guide wire and exchange with that, and then you do dilatation. This is slightly historical interest. We do not routinely use ERCP cannula now for cannulation. Historically, there are uncurved cannulas were also available, but most of the time, whatever is available now is pre-curved cannula, and most of the cannula will have the shaft diameter of 5.5 French, contrast to sphincterotome, which are 7 French. So they are thinner device, more flexible, more malleable, and the softer device. And with little bit of grooming, the direction can be changed, although they are designed pre-curved mostly. And there are different degree of tapering available, which I'm going to discuss in a short while. And then there are various specialized cannula available, like triple lumen cannula and ball tip cannula, which is I will be discussing. There are some general principles, like one should be using as blunt cannula as possible, because the tissue trauma is the soil for complication, because that leads to edema of the papilla, obstruction to the flow of pancreatic duct, and pancreatitis. And then there will be bleeding, and all the anatomy will be obscured. Then there will be, because of trauma, there will be swelling. The papilla will swell, and if you don't cannulate within few minutes only, it will swell, and all the anatomy will be distorted. So to make least traumatic use, the idea is to use least traumatic papilla, least traumatic cannula in the beginning, so that most blunt cannula we try to use. So what we have is called a standard ERCP cannula. So this, as a sample, I'm showing you from Boston Scientific. So a standard ERCP cannula will be accepting 035 wire, and tapered cannula also will be accepting 0.035 guide wire, but ultra taper will we accept only 2.25, and there is very specialized cannula which is 543 will accept only 0.18 guide wire. So that one has to remember, so accordingly, and then this will change. Like in Boston Scientific, if it is blue, then you know that it is compatible with 0.035. It is black, then you understand that it is not compatible with 0.035 guide wire. So the standard ERCP cannula will be the shaft diameter, outer diameter will be 5 French, which will taper to 4.5 French, and which will taper to 4 French. Sorry, which will taper to 4.5 French, and then 4 French in case of ultra taper. So 5 to 4.5, 5 to 4, and 5 to 3.5. And in case of 543 ERCP cannula, which is beyond ultra taper, so this will taper down to 3 French. So outer diameter, shaft diameter will remain 5 French, and then it will taper down to 3. And this will accept only 0.18 guide wire. Then we have ball tip cannula. So ball tip design is like that. There is a ball like. So this is used in the situation. This is exam question. So used in situation, where do you use ball tip cannula? So then when the papilla is very friable, and when the papilla is friable, either there is like portal hypertensive duodenopathy, but more common than that, there is ampullary growth. So if there is periampullary carcinoma and you are trying for within 1 or 2 cannulation, everything becomes blood mixed hemorrhagic field. So in that situation, we use either a standard cannula or the ball tip cannula. So it is least traumatic. So in those situations, but other situation will be like portal hypertension situation, we will be using ball tip so that there is minimal trauma. So that is the least traumatic. So then we have certain specialized cannula. So tandem XL is triple lumen. So in contrast, these cannula are only double lumen. You can see there are only there are 2 ports only. So these are the double lumen. So either you can have the guide wire and then contrast injection from the side port. But what used to happen that it used to soil the guide wire completely. So friction used to become more after injecting contrast, and exchanger become difficult. In triple lumen, that is not the problem. So triple lumen, one will accommodate the guide wire, and what are the other 2 lumen? The 2 lumen both are for contrast injection. So there is single port for injection, but the contrast will go through 2 lumens. So that you have to understand triple lumen. Otherwise, you will keep wondering, okay, one we have kept for guide wire, one we are injecting, where is the third lumen? Third lumen, because from outside you are injecting in one port, but inside there are 2 lumens for conducting or for taking the contrast. So these are the 3 lumen. So this is much thicker cannula compared to ERCP cannula. So this is 7 French in contrast to the standard ERCP, other ERCP cannula recurved, which are 5 or 5.5 French. And this accepts 0.035 wire. So that is important. And the length will be very similar. So tandem XL is triple lumen ERCP cannula that we discussed just now. Then we have several stone retrieval devices. There are certain rules that most commonly we use balloons. So these balloons are different compared to dilatation balloon, like CRE balloons which we use. These are completely different from that, because what happens that extraction balloons will have a right angle shoulder, so that they are able to pull or bring the stone down, whereas the dilator balloon are always tapering. So if you see CRE images or any of the dilator balloon, then that will be tapering. So that is very important to understand. Then the size of the balloon can be different, and it can be anywhere between 7 or 8 millimeter to 20 millimeter balloon. And what size balloon you choose? You choose the diameter of balloon according to the diameter of the bile duct or pancreatic duct from which stone you are extracting. And then which situation you will choose the balloon and which situation you will choose the dormia. So the rule of thumb is, if you have a small stone, if you have multiple stone, in those situations, balloon will be preferable. Where you have one or two stone only, and where a stone is relatively large, in that situation, the Dormio basket may be a preferable device. So that is the rule of thumb. Then we have option of contrast injection in all the balloons, and this injection port can inject above the balloon or below the balloon. Most commonly, we use above the balloon because in that situation, we will be able to do balloon occlusion cholangiogram, which we say balloon occlusion cholangiogram, because at the end of the procedure in bile duct, to check completeness of clearance, we always check. What is the advantage of injecting below? Sometimes what happens that stone get pushed in intrahepatic position or deep into the duct, and then we want to push down. So in that situation, the balloon which injects below will be useful. So we will try to pass the balloon above, and then through the contrast port, either we will inject contrast or saline, and then the stone will be pushed down. So that is the advantage. So here you see two lumen, two for contrast, one for guide wire, one for injection of contrast, one for balloon, and one for guide wire. So triple lumen sphincterotome. So this is available in balloon diameter of 9, 12, and 15 millimeter size. So that is how it is available. So this is previous version. Now the newer version has come. So single device, one can use different volume of injection, and it can achieve different diameter. So different amount of air by injecting. So it is marked in the syringe. Some of the companies are providing different syringes altogether, so that can be used. So that is available. Multi 3 is the balloon which is available from Olympus, and this is the single balloon which can be achieved from 8.5 to 15. So 3 diameter. So what happens that it provides syringe, which is especially designed syringes. So you are the 3 syringes you are seeing. So different syringes, different diameter syringes. So whichever diameter you want, you pick up that syringe. So these are very interestingly designed syringes. So it has a small hole created. So accidentally also you cannot inject more air than what is required. So they have designed in a manner that exactly the amount of air which is required. So you pull as much as you want comfortably. All the air will go out till the time exact volume you start injecting, only then will start injecting. So that is the built-in safety mechanism in multi 3. So this is 8.5, 11.5, and 15 millimeter diameter. And this is obviously guide wire, wire guided device. So it goes over guide wire, and the tip diameter is 4.5 French, as is most of the catheters, it happens. So I explained you already that for small stones, multiple stones, the choice is always balloon, and it can be used like that. When you are extracting, you always treat the stones like your enemy. So what is that? So you don't give enemy opportunity to unite. So you break the enemy and then or disperse the enemy or tackle the enemy one by one. So like you have 6 stones, so you will not try to go above all the 6. You will try to take 1 or 2 stone, and then you try to pull it, and then one by one. So that is very important, because otherwise force transmission is so poor that a stone will not be extracted, and erroneously one will say that this stone is not coming out because this is large in size or the lower CVD is narrowed. Whereas if you take one by one, most of the time you will succeed. So it is very important that you start sweeping from the lower third, then your middle third, and then from the upper third of the CVD, you will be taking back. So that is interesting. This is interesting device. So basically what this device is called a Stonetome. Stonetome, this is from Boston Scientific or Microvasive. So this combines the stone extraction balloon with the sphincterotome. So they have given option that balloon can be ahead of cutting wire, or balloon can be behind the cutting wire. So whatever the preference of operator, so that's why they have provided both the options. And the tip length is 5 millimeters, so only short nose version, and then we have long nose version, 20 millimeters. So both versions are available. and the balloon diameter is fixed diameter 11.5. So in the dedicated balloon, we have option of 8.5, 11.5, and 15. And I told you how do you decide how much inflate? This is the diameter of the bile duct where you are inflating the balloon that determines the size of the balloon. So you decide according to the diameter, either the same diameter as the bile duct or maybe 1 or 2 millimeter more than that. So otherwise, balloon, stone will be keep sleeping. Then there is another device which came from Olympus. So this is Stone Master. This came later on. So this is also has a balloon and with a sphincterotome. But this balloon is not stone extraction balloon. This is a dilator balloon like CRE balloon. So you can imagine you have a device which has got a cutting wire or the sphincterotome on which we have add on a CRE type of balloon. So you can see this is not a right angle shoulder. So this is a tapering type of shoulder solder out here, and then you have a multi-diameter balloon out here. So this can achieve different diameter at different pressure, like controlled radial expansion balloon, CRE balloon, which you are so you see so frequently. So this is called Stone Master. So this cannulated like a normal cannulation you can do, and then you cut, do a sphincterotomy, then dilate using this balloon, and then do a stone extraction using separate dedicated uh, stone extraction balloon. So here what happens that cutting wire, you can opt for either 20, 25 or 30 millimeter. So that is the option company has provided you. That shaft diameter is again here 7 millimeter, which tapers down to 4.4 millimeter, which is you had seen that Clevercut, it was 44 millimeters. So the same specs they have kept. Working length is again same. And the balloon, two types of balloon are available. One is 8 to 12 and other is 12 to 18 millimeter. So 18 millimeter we dilate occasionally only. Uh, 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 the papilla, most of the time we either 12 or 15 is sufficient. So that is depends on the pressure. So dilatation pressure is measured here in atmosphere. So 0.5, 2 and 3.5 atmosphere. It will achieve the first, second and third diameter. And the balloon length here is 40 millimeter. So that is very important to understand. So that is, and this is cylindrical balloon. So whenever you are dilating, so you can have either hourglass balloon or cylindrical balloon. So hourglass is basically dumbbell shaped, which is narrow in the center and broader at the ends. So that has the advantage that it will automatically slip in or slip out and will take the waste to the desired area where it is, where there is narrowing. But there the diameter is not very accurate because proximally and distally there are more diameter. So that type of balloon can be tricky to use. So most of the balloons which we are using are now cylindrical balloon. So this is cylindrical balloon, and that is what and 4 centimeter length. So that you keep stabilize on the pipeline, you do dilatation and pressure. You inflate the pressure using a device which I'm going to show you. So this can be 0.5, 2 or 3.5 atmosphere. So either it can be PSI or atmosphere. Here the unit is pressure, atmosphere. So you will use this device. So Stone Master, again, I have shown you cutting wire, again 20, 25, 30 options you have. And then balloon size, it can be 12, 12 to 18 or 8 to 12. So two types of balloon are available. So that can be used. And this is the inflation, dedicated inflation device is required. So this is a rotational device which raises the pressure, and this is the pressure gauge, and this is the connector with three-way connector. So this will connect to the uh, Stone Master device. So with the Stone Master will be inflated with the help of this device, and maximum pressure is 15, but you require only up to 3.5. As you have seen that at 3.5 atmosphere, it achieved the final. So that is the reserve they have given quite a lot. Olympus has got dedicated basket of stone management system, some of which we have studied and some of which we are going to study. So I showed you already that stone extraction balloons, which are multi-3 from Olympus. The 3 diameters you can achieve with the same balloon using different volume of injection. Then you had a stone master, which I showed you that there is a cutting wire, there is a sphincterotome type of device, then dilating balloon. Then we have other devices which are called Dormia basket. So different types of Dormia basket, which we are going to see. And those devices we need to see and learn a bit. So Dormia basket, I told you in general. So that when we have 1 or 2 stone, then basket is preferable to balloon. The main risk with basket is getting impacted, and it is because it is a metallic device. So this is can be little more traumatic. So if one is careless with the use, then it is possible to perforate the duodenum or bile duct using the Dormia basket. So that's why it requires a little care and a little experience for its usage. And what happens that sometimes where Dormia gets impacted, so one need to have what is called emergency lithotripter or salvage lithotripter to make it free. Otherwise, one will be stuck and will not be able to take out the scope. We'll have to cut the wire of the handle of the basket. So that is the very insulting situation for the ERCP operator. So that's why the Dormia usage has gone down, but there are certain advantages of Dormia. This is much more effective stone extraction device. This is most of it can be reused, so the cost will be less, and then bigger stone possibly more effectively can be brought out through this. But more and more with ability of large balloon dilatation, this is becoming less and less. It is required. There are different types of baskets available. As a rule of thumb, you will see that there are soft basket and hard basket. So soft basket are for routine stone extraction. Hard baskets are mainly for crushing the stone or lithotripsy. So that is. So beforehand, you need to know where your basket is compatible with use with lithotripter or not, because there are baskets which are can be used for routine stone extraction like a soft basket, and then they are compatible with mechanical lithotripsy. So those are obviously preferable, because in case you have impacted basket or if you fail with a stone extraction, then you can pass the crushing device or lithotripter, and then it can be. Most of the baskets are unfortunately not wire guided device. So some of the baskets, so that should be remembered. And most of the baskets are not rotatable. So only few of the baskets are rotatable. So that also one should be aware of. So this is a standard 4-wire basket. So as you can see that this has got a metal tip, but this is deliberately made bulbous, so it doesn't produce trauma, it doesn't fit. And this is plastic sheath in which there are metal wires. So again, this has been made atraumatic. So 4-wire is standard 4-wire basket. But there are different variation of these. These are available. Only some of them I will be showing. So it can be, you imagine that in place of 4, you can have 6-wire, you can have 8-wire. So what is the advantage? That if larger number of wires, it is easier to trap the stone. And smaller stones are easier to trap with large number of. So you have very small stone, then possibly 6 or 8-wire basket. But you have large single stone, then possibly 4-wire basket will be good enough. And then these wires are going obliquely. So these are called helical basket. So these are 4-wire helical basket. Again, this is not a wire guided device, because here you see blunt tip, which is to prevent perforation. But all these devices permit contrast injection. So during course of stone extraction, if you want to see the number and position of a stone, then you can inject contrast, and then it is possible. This is called flower basket, which is only available from Olympus. So if you see, each wire is going, dividing, and then reuniting at the tip. So initially, which starts as a 4 wire, ultimately becomes a 8 wire basket. So this used to was designed to help in easy trapping, and it does help in that aspect. And the second advantage is the wire guided version of this basket is available. So in difficult anatomy, where it is otherwise difficult to pass the basket, there it can be passed over the guide wire. And another advantage that this is available with mechanical lithotripsy. So initially we can start with routine stone extraction. If we succeed, fine. Otherwise, we can take the mechanical lithotripsy VML, which I'm going to show you, and then the stone can be crushed. So this is tetra catch. This is wire guided basket. So I showed you previous baskets; those are not wire guided. So this can be passed over wire. So in difficult situation, also it can reach in the right hepatic duct, left hepatic duct where you want to go. So that is the advantage of tetra catch. Then we have a very dedicated device. It's called Vorticatch V stone retrieval basket. This is again Olympus. So this is basically, you can see the wire configuration out here. So what is available as 6 or 8 wire basket. So that takes a peculiar shape and towards the tip, and that is helpful particularly in situation where difficult situation like the stone are stuck in a bile duct pocket, bile duct diverticulum, or when we have done mechanical lithotripsy, some of the fragments are stuck somewhere like cystic duct stump. In those situations, it tends to work better. So stone fragments, because of configuration, even in a smaller fragments, it can catch, and that can be removed. Then we have mechanical lithotripsy. Then we have mechanical lithotripters of different types available. So the commonest lithotripter which we use is called trapezoid. It has many advantages, so that's why it is quite a popular lithotripter, because it can be used. It is intermediate between the soft and hard basket. The basket is such that it can be easily introduced. It is can be over even over it is can be over guide wire also. So even in difficult position, the basket can reach. There are different size basket available: 1.5, 2, 2.5, 3. So depending on the size of the stone, size of the bile duct, appropriate size basket can be picked up, and then it can be used like a routine stone extraction basket, and stone can be extracted. When we do stone extraction, we always avoid completely closing the basket, because that is the soil for basket impaction, which I told you can be very humiliating for the operator. So we try to keep the basket open and take down the stone and pull through the ampulla. If it succeeds, then it is fine. If it doesn't succeed, then this has got the sheath which which can crush, which can be used for crushing. And then we use this device. This device, all of you know, sometimes you call it CRE gun. So this is that word should not be used. This is not gun, or this is not for use for firing. This is an inflation device. This is called alliance inflation device. Why alliance? Because this is used for inflation of CRE balloon, and this is also used for crushing the stone using trapezoid basket. So here you see a knob. So if you change the direction of knob, the movement of handle will change. So when you are using in this direction, you will be using with the CRE. When you keep the direction this side, then you will be using with the for the stone crushing. With the stone crushing, it will move in this direction. So the wire will close and the stone will get crushed. So that is how it works. So again, I showed you that beforehand you can order as per the catalog of the, depending on the basket size, which can be 1.5 to 2.5 or 3 centimeter diameter. So that is the trapezoid basket. This comes from Olympus. This is called lithocrus. This is a hardwire basket, and this is a 4-wire helical basket you are seeing, and this is the lithocrus handle. So you load into this, and the opens up, and then there is a metal sheath which slides, and this keeps coming back, and a stone will be crushed. So lithocrust. So these are the mechanical lithotripter. There are many more types of mechanical lithotripter, but there is another category which I will like to discuss is uh, which is called emergency lithotripter. So that is very important. So I have shown you two types of emergency lithotripter. So what is when do you emergency lithotripter? Say for you are trying for a stone extraction, with the basket got impacted, and then you are not able to take out. So then what you do, you cut using some of the uh, devices which are available for cutting the wire of the lithotripter, and you pass that wire through this metal sheath. You remove your scope, and after removing the scope, so this is not a through the scope device. This is after removing the scope, and you pass this device wire through this. Wire comes out from here, and then it goes through this, and then you lock out here the wire. So you tie the wire by making a loop or knot, and then you rotate this. So the basket will slowly close inside it, and a stone will get crushed, and the basket will be freed, and then it will be taken out. So there is another device available which works very similarly, but there the sheath has been redesigned. That is concuss device from um, Wilson Cook. So that is goes through the scope and works exactly in the same manner. So there they have a special basket where what they have done, that handle of the basket can be opened, can be removed. So there is removable handle. This handle is can be opened, and then that can be passed through the concuss device, and that goes through the channel. So one need not remove the scope, and can crush the stone. So that is called concuss device, which is available from some of the manufacturer. So simple things will sometimes get very complicated. So like measuring length, we never thought can be an issue. But in case of a stent, you need to know how the stent lengths are measured. Okay. So some of you who are assisting in ERCP might be knowing or might be knowing part of it. Others who are not routinely assisting in ERCP and or occasionally assisting will be a surprise. So when you can have stent without flap, there are no issues. It is measured from end to end. So you see from here to here, it will be measured and 10 centimeter. So then it is 10 centimeter, no issue. But when you have a stent with a flap, side flap, so when you see a 10 centimeter stent, it is between the flaps. So this is actually usable or effective length, which is 10 centimeter, which is mentioned as a length. Actual length will be much more. Okay, so this is how you are able to see this picture of cotton link biliary stent. So this is how it is measured. But if you see double pigtail stent, so most of the double pigtail stents now have radio opaque marker or black marker at the from where double pigtail stent starts. So double pigtail stents are measured between the pigtail. So it is the straight portion. So when you open, it will be very long. So many times you will see that if you take 10 double pigtail stent in bile duct, and then very large portion will be hanging in duodenum, because bile duct per se is 10 centimeter, but the stent when it opens up, it becomes virtually 17 centimeter or sometimes even larger than that. So that becomes very long. So you know that double pigtail, it is measured between the pigtail. But in case of Tannenbaum stent, there is no confusion, because here you measured between the flaps. So again, in Tannenbaum stents, it is measured between the flap. And those who are not conversant with Tannenbaum, there is different in this cotton Leung biliary stent. or routine microvasive stent which we use. So this is full thickness flaps. So what happens that flaps is raised, then the hole becomes apparent with the lumen of the stent. So this is full thickness. Whereas these flaps which are raised here, they are partial thickness flaps and there is no hole. So there is only the bile will be entering or either from the end and exiting from the end. In between, there is no hole, and these are all partial thickness. So this is Tanner-Bohm biliary stent. But here again, the length will be measured in between the flaps. And when you have multiple flaps, then the this is how the length will be measured from one end to the first flap at the other end. So that is how this is very complicated system of measuring, but you should be aware of it. When you have multiple stents, particularly pancreatic stent, Guinan pancreatic stent, from the nth to the flap, because first flap, this flap you will be leaving at ampulla. So that is how it is measured like that, because this is Guinan pancreatic stent. So this is how it is measured. But when you have single pigtail stent, then it is straightforward that pigtail you don't measure, and from where the pigtail starts to the other end, you take the stent. So this is how it is measured. And single pigtail here, if you have single pigtail with a flap, so between the flap and the pigtail. So that is how the length will be measured or minceant. And when you have G-man stent, say then the from end to end. So if you have no flaps but you have side holes, then you will measure from end to end. So that is the complex system of measuring the stent. So simple measuring has become a task. So that is very very important. So that was all for the day. And let me see if you have, I think we have some questions so that we can tackle. Somebody is writing AK. I don't know the full name. So can you explain with example when to use short nose and when to use long nose? So for routine purposes, always I said that short nose sphincterotome is preferable because better maneuverability. Long nose situation we tend to use like when we are working quite away from papilla, or for some reason like if you have papilla at the margin of diverticulum where you want your direction of cut to be very precise. So one can go for the long nose sphincterotome. So it is very stable position and very precisely in that direction one is cutting. Or if you are away from papilla, then you want a very good stability because you are away from papilla, then distance will be too much. So then you want a stable position. So you pass this long nose sphincterotome there, is achieve a stable position and cut it. So those are the two examples which I have given you, but there can be many more. So how to know hard or soft stone? No definite way of knowing it. So you cannot make out radiologically or otherwise. So only by attempted. Sometimes the story is still more complex. Sometimes what has happened that we have interpreted that, okay, stone is approximately 20 millimeter in size. But what happens that is actually not one stone. This is conglomerate stone giving rise to one shadow. So conglomerate as a stone showing shadow, and then what we interpreted as one stone was actually multiple stone, and 20 millimeter stone we were able to extract with use because during process of extraction, all those they left the hands of their friends and they separated, and then we were able to take. So that's why I told you that you have to tackle them like your enemy. So don't give opportunity them to unite. So always when you have a very large shadow coming up, then you always maneuver with your sphincterotome, maneuver with your guide wire repeatedly, try to move the stone. So if there is conglomerate stone, then it try to disintegrate, separate, and then you will be able to know the exact size, and also size measurement will be accurate. But very soft, easily crushable versus difficulty, crush with difficulty, you cannot say. Sometimes it is said that white stones will be more difficult to crush, but because those stones are inside and you are not seeing the stones, so that point doesn't hold true. So there is no foolproof method for that. Then how to groom a sphincterotome for the pancreatic cannulation? Palak is asking. Unfortunately, I don't know how to demonstrate it here. I don't have a scope. I am taking this lecture from my home, so I don't have. But normally, when we try to make a two full circle of that from the tip of a sphincterotome over our finger. And for grooming for the pancreatic duct, we use our right index finger, or for grooming on the left, we use our left index finger. So we take the sphincterotome. We take the sphincterotome and groom on the left finger. So that is how I will see. I will try to load some video on YouTube, maybe later after 1 month or so. On when I'm planning to load some videos on selective cannulation, ERCP videos. So there I will try to show.